Thank you, Dr. Flock, for that wonderful lecture, and especially giving bullet messages throughout your lecture. And I think that would be extremely useful to a busy clinician to see the messages very clearly getting into his day-to-day practice. I think there are some questions, but I think I'll take the privilege of being the program director and ask a few questions. And I think, when would you consider starting phosphate binders in patients of chronic kidney disease? Say, I would say, if the calcium and phosphorus levels, especially say in early kidney disease, is normal, and one would hope that as the kidney disease progresses, would you want to start it earlier, or would you want to see when the phosphate starts rising? Because there was an earlier feeling that if you block the phosphate absorption, even in early stages of chronic kidney disease, you may not allow hyperphosphatemia to hyperparathyroidism to occur. Would you consider that as a logical kind of a thing?
I was afraid somebody would ask that question because I don't have an answer. I mean, you could just as well argue you should start a phosphate binder when your FGF23 starts to rise, which would be even much earlier. Now, in all honesty, I don't know. So far, the clinical trials that we've seen haven't documented any benefit from normalizing phosphate in, let's say, CKD3 or CKD4. But these are all short-term studies, and nobody has cared to really do a long-term study. So if it were myself, I would probably go for good dietary counseling initially. And if there's overt hyperphosphatemia, I tend to treat these patients. We may have, and we will have, much better options in the future, and totally different options from phosphate binders. For example, several companies pursue blockers of NaPi2A, which is our main phosphate pump in the tubule, so that you would increase phosphaturia. Many companies work on blockers of intestinal phosphate pumps. There's tenapanor now, which is a sodium proton pump inhibitor that gets rid of phosphates. So we will have much more tools in the future to affect phosphate, and very hopefully somebody then will care of doing a study lowering phosphate in pre-dialysis CKD. But I agree with you conceptually. If there's overt hyperphosphatemia in CKD4 or CKD5 not on dialysis, I would treat it, but more because of personal opinion.
I also liked your comment about the KDIGO guidelines, that these guidelines look at numbers, look at evidence, but then in these guidelines, sometimes practical management of patients as to what you emphasize, that if the survival of a patient, your common garden patient 70 to 75 years, is 2 years of life, and those 2 years you would not be as much worried about phosphate binding as would be nutrition. In our country, malnutrition is so prevalent in our patients. So I would be more interested in improving the nutrition of these patients rather than worrying about phosphate at that point of time. Would you be okay with that kind of
absolutely
outlook?
Absolutely agree. I mean, the hypertensiology people have learned this, the diabetologists have learned that there's a different target range in the elderly as opposed to younger patients. We have different hemoglobin A1C, we have different blood pressure targets, and we still have to learn it. I fully agree. In my 80-year-old patient, I care about quality of life and nutrition, and much less, I mean, if their phosphate is 9, yes, I do react. And I tell them, hey, consider your eating habits. But if their phosphate is 7 or 7.5, I really care very little.
Yeah, thank you. I will now request any of the moderators want to have a question, please unmute yourself and you can ask the question, and then I'll go to the questions which are in the chat box.
Yes, sir. I want to have one question. That most of the studies are in dialysis patients, but not in really CKD non-dialysis patients. I want to have your answer, sir.
Well, in a way, that's what we just discussed. In the pre-dialysis phase, we're totally in the dark because nobody has cared to do a good study. Maybe you can do one in India. You're so many people. Why not do a study in pre-dialysis?
Yes. Yeah. Yes, Dr. Sampath Kumar, you seem to. Yes.
Several years ago, in my unit, I have done a study on use of nicotinic acid as a phosphate-reducing agent. I had published it.
Yes.
But somehow it has never caught the imagination of the scientific community, and a few studies have come up recently, and they have all been negative.
Right.
But my own experience, the lowest pill burden is nicotinic acid. With a single dose of this drug, I have been able to reduce the phosphate level by a factor of 1 to 1.5 milligrams.
Well, we had the so-called NOFOS study conducted in Central Europe.
Yeah.
The study confirms what you say. Nicotinic acid can lower phosphate, but in that phase 3 trial, the unfortunate observation was it did so after a few weeks, but after 1 year, there was no difference to placebo. And we had the puzzling observation, and this raised a lot of concern, that there was a pronounced increase in herpes zoster infections in the patient, herpes zoster in the patients on nicotinic acid, and that really caused concern.
Yeah, that's really educative for me, because I don't have experience of the large number of patients over many years. These are all short-term experiences that I'm speaking.
If you tolerate it and if it helps lowering your phosphate, it's nice because it's just a small pill. Yeah. But there are several companies now working on more. Nicotinic acid is a fairly non-specific inhibitor of intestinal phosphate transporters. There are several companies working in this field, and I think the most advanced one is Chugai in Japan. They just published a Kidney International paper on their EOS compound, which is a very specific inhibitor of phosphate transporters, and that may really increase our armamentarium.
Thank you.
General Verma, you wanted?
Vijay?
Yes, Hemant.
Yeah, Hemant. Dr. Floege, thank you for an excellent talk. My question is regarding avoidance of calcium-based phosphate binder. Now, if you look at our Indian population, many a times by the time you diagnose them to have CKD or end-stage renal disease, many of them are malnourished, and we have a typical picture where calcium is, say, like 6, 7, and a phosphorus of, say, 8, 9. In that situation, when I was student 35, 40 years ago, my boss also used to say that we use 7 milligram of calcium in the dialysate also, and that is because our patients are supposed to be hypocalcemic to begin with. Now, same situation remains here, though we don't use high calcium dialysate, but in that situation, wouldn't it make a sense to begin with calcium-based phosphate binder, build up the calcium level? Also, if you begin with cevilamar, which is also known to have hypocalcemia as one of its side effects, in that situation, how does one go about?
Well, you're asking, I believe, a very complex question. The guidelines now really stress, and I showed you initially the association data, that hypocalcemia is nothing that I really worry about. If the hypocalcemia is not massive, so anything below 7.5 I would worry about, but anything above 7.5 I'm not really worried, because we have learned that that is not a dangerous situation. But to answer your question more specifically, I guess it depends on your patient, and in particular on the bone status. what we have learned from the calcimimetic studies is that there may be situations where it is a good thing to treat hypocalcemia, namely when you have started a calcimimetic and you have induced something like a hungry bone situation. It's probably a good thing to give calcium to that patient so they can remineralize their bone. But it's totally different from the patient with a suppressed or low PTH, where the calcium simply isn't incorporated in the bone, and I would readily accept hypocalcemia in that patient. And I would be very cautious in loading that patient with calcium because it simply cannot go to the bone. And as this Turkish study has shown, if at all, it ends up in the vessels. I don't know whether that really answers your question.
So what would be the role of vitamin D in this situation vis-a-vis hyperphosphatemia?
Same answer. I guess we really have learned from the calcimimetic studies that if you have active bone turnover and remineralizing bone, that is when you should have and you can have more vitamin D. I'm very, very, very reluctant in giving high doses of vitamin D, as we used to do in the mid-80s. My first teacher was Stanley Sheldon, and we always had this big fight with the French groups about vitamin D. I think we've poisoned many patients in the old days with too much vitamin D. So I've become very restrictive in using it. And in particular, if the PTH is low normal, so if the PTH is below 300 in a dialysis patient, I try to avoid active vitamin D, in particular if there's hyperphosphatemia. So phosphate should always come first, because that obviously is the much more direct stimulus to PTH, and is something that I'm much more concerned about.
Okay, if then there is a question, Dr. Floege, on that. How would you maintain sucroferric oxyhydrate after 3 months? Would you continue with the same dosages, or would you change, or?
Depends on your clinical success or non-success. If my patients like it and if they take it, I simply let them chew 1 tablet per meal. And again, you're touching on a very important issue here. My smart young patients, I tell them, hey, look at what you're eating. If you're just eating an apple, it doesn't make sense having a phosphate binder. But many of my patients have some degree of dementia, and for them, it's much easier to memorize 1 tablet per meal, full stop, don't think about it. And I guess that's the beauty of this drug.
Okay, is there an effect on glucose, serum glucose or glucose levels or something that you've seen?
No.
There's a question in the chat box.
No, there's no effect.
There's no effect. And then there is a question also that, is there a randomized trial which has shown a mortality benefit with any of the phosphate binders?
No.
In a randomized controlled trial?
No, we're still waiting for that. There are plans to do this, I believe, in Canada and in the UK, randomizing patients to a high or low phosphate and then seeing what the outcome is. But none of that trials, to my knowledge, has started yet.
Can I?
Yeah, General Verma.
I just wanted a very nice lecture, a very enjoyable lecture. I just wanted to ask, at what level or at what stage, if a person has got hyperphosphatemia, what is your choice of phosphate lowering drug? At what stage you jump to sucroferric oxide? Is it your first choice?
It depends on my patient. And I guess there's not an easy answer to this. First of all, I take into account age, life conditions, nutrition status, comorbidity. As I said, in my 80-year-old patient, I simply care very little. In the younger patients, I care a lot. I would not place my younger patients, and younger is, well, you all know the definition of age. It's your age minus 5. That's young. So in my case, that would be anything below 60. I would place on a calcium-free phosphate binder. Yes, if they tolerate sucropheric oxyhydroxide, that would actually be my first choice. But I have had a patient where the wife of the patient said, hey, you have brown teeth. You can easily brush it away, but it leaves some stain on your teeth, or it can do so. I had a patient who told me, look, I don't like this diarrhea and I don't like the black stools, but many will tolerate it. And if they tolerate it, I think this is close to being the perfect phosphate binders, even though this is a pharmaceutical industry sponsored event today. I really believe that it fulfills a lot of the demands that we would have to an ideal phosphate binder. You have no accumulation, it's very effective. It adds, if at all, a little bit of iron to the iron deplete patient. It has no risk of toxicity. It doesn't have drug interactions. So what else do you want? A cheap price, yes.
Well, there is another question on does it cause hypocalcemia? And what's the effect on FDG23?
No, it doesn't cause hypocalcemia because it has no direct calcium binding effects. And FGF23 will go down as you lower phosphate. But that's not specific for sucropheric oxyhydroxide. That's seen with all phosphate binders. The moment you lower phosphate, you lower FGF23.
And I think you also showed that the effect is equally good in CAPD patients as well as in hemodialysis patients.
Correct, yes.
And I think that's what you showed. That's a question there as well. So I think I would now request Dr. Floege that you can join if you want to in one of the sessions, which is going to continue zone-wise. But otherwise, I would like to thank you very much for being with us tonight, at least here in the evening. It's an afternoon for you, and you are very welcome to join any of the zones if you have time. And okay. Thank you very much. Thank you very much. It's a pleasure. And I think now we will have the zonal meetings, and we have moderators as has already been said earlier. The North Zone, the moderator is Dr. Bala. The West Zone moderator is Dr. Hemant. South Zone moderator is Dr. Sampath Kumar, and the East Zone moderator is Dr. Ray. So you can start your meetings right now in each zones, and I will probably try to shift between zones and try to see how things are happening. Okay. Thank you very much. Thank you very much, Dr. Floege. And I must also say that it's been a pleasure to have you with us this evening. Thank you. Thank you.
Thank you all.
Very good lecture. We all enjoyed it.